Hi, I'm Lyndall Parker-Newlyn. I'm Medical Director from IMGSOS. This video is about understanding hepatitis B serology, and it seems to be a common stumbling block I find as I'm preparing doctors for their fellowship exams. And I know some medical students have difficulty with it, so I'm sure there's a few of us across the profession that just find it tricky to understand. Hopefully this will make things a little clearer for some of us. So why hepatitis B? Look, it's a common clinical problem and it's a common exam question. Because of the different types of antigens and antibodies we're measuring, it can be easily misconstrued if you're not keeping your wits about you during an exam condition, and it's a common gap in knowledge. I think one of the reasons that we struggle with hepatitis B serology is that it's often taught to us in a tabulated form. Here's all the results, here's all the possible permutations and combinations, go away and rote learn it. I personally don't find that's particularly effective at all, and I think if you're trying to measure any of these things and you're trying to learn anything like this, it's a whole lot easier if you actually understand why, what it is you're measuring, why you're measuring it, and then you can figure it out from first principles, rather than trying to stick one of these tables on your desk and just keep reading it till you remember it. It would be better, surely, to actually understand the physiology behind it and then be able to reproduce that in your head during the exam. Hopefully I can help that happen with this video today. What I want to do is start by explaining about the virus so that we avoid the rote memorization of lab results, we understand a simplistic version of virus structure, and then no matter what the example is, you can figure it out. Now, I'm not a microbiologist, I'm a GP, so I've simplified this quite a bit to a way that makes sense to me and hopefully makes sense to you. Let's start by constructing the virus. Firstly, in the centre of the virus, we've got viral DNA, hepatitis B DNA. Some of this is single-stranded and some of this is double-stranded. And that's important because we'll come back to it later. That's then surrounded by a core, and this core of virus has, this viral core, has antigens. And those antigens can be measured, and those antigens will produce antibodies when they're seen by the body's immune system. Around this is then an envelope, and this viral envelope is studded with antigens as well, and these are called the envelope antigens. And then finally, there's the antigens on the surface of the virus. There's actually a whole different kind of these, different sorts. I've just put two different sorts here just to make a point. But there's a range of different sorts of these antigens, and these are the ones that are actually on the outside of the virus and that are easily identified by the immune system. So putting all that together, you've got the DNA in the middle. That's surrounded by the core antigen, which is surrounded by the viral envelope. And then finally, there's the surface antigen on the outside. These are all named, of course. So you've got the viral DNA, the HBV DNA in the centre, the core antigen, the hepatitis B core antigen, so HBsAg. Around that is the envelope antigen, so HB for Hep B, E for envelope, Ag for antigen. And then on the outside is the surface antigen, so HB for Hep B, S for surface, A for antigen. So that's where the naming comes from. Let's have a think about pathophysiologically what this means when you've got a viral infection. We're going to start with the surface antigen. So HBsAg, surface antigen, is S for surface. I sometimes think about it as S for shell, like an eggshell, and I know it's not actually brittle like an eggshell, but it kind of works in my head. It's how I help to remember it. The surface antigens, as I showed you, are studded on the outside of the virus, and they're detected in high levels in the blood in acute infection, also in chronic infection. It indicates the person is infectious due to the presence of these viral proteins. Now, what you'll find is as a normal part of the response to infection, the body makes antibodies to the surface antigen. And because there is so much surface antigen with a viral infection, they often make high levels of antibodies. Once the person forms those antibodies, they usually clear the virus and they're usually immune. Okay? So the antigen is called HBsAg hepatitis B surface antigen. So the antibodies are called HBsAg, hepatitis B surface antibody, or anti-HBs. Okay? And you'll see on the top of this slide my little HB surface antigen there, my little yellow triangle, and there's the HB surface antibody trying to connect to it. Okay? Now, the reason the eggshell is important is I sometimes use that as an analogy when I'm explaining this to patients. Because the other thing that's important to remember about the HB surface antigen is that's what's used to make up the vaccination. So my little man here with his Hep B vaccine, that Hep B vaccine is just full of synthetically produced surface antigen. The way I explain it to patients where the eggshell comes in is what I say to patients sometimes is, if I give you a piece of eggshell, even if it doesn't contain an egg, even if it doesn't contain a yolk, you can recognise it. You know what it is if you see it again. Your immune system's the same. We only have to give you a little piece of the shell of the hepatitis B virus for your body to remember it and know what to do next time. So that's sometimes why I remember about S for surface and S for shell. What this means though, when we're testing, is that patients with hepatitis B infection will develop antibodies to the surface antigen, so they'll develop surface antibodies. So will patients who've been vaccinated. They will also develop surface antibodies. So the presence of antibodies in large amounts indicates immunity, either from cleared virus or from vaccination. So you can't actually tell from surface antibody at this point which one it is, but other tests will allow us to see that, and I'll explain those in a moment. The other thing that's important to know is the antibodies do generally decrease over time. So we've got our surface antigen, and I've now added a little surface antibody, so you know how those two are linked. Let's move on to the core antigen. So the core antigen, C for core, and there's a little apple core to help you remember that. The protein is actually in the core of the virus. Now, as I said, the vaccine is only made up of surface antigen, just enough to stimulate the immune response. So core antigen is not found in the vaccine. So vaccinated patients won't have core antigen or any response to core antigen. The funny thing about core antigen is we don't test for it. What we do is we test for the core antibody. We test for the response to it. Now, the body makes core antibodies quite quickly at the onset of symptoms. And so in acute hepatitis B, you'll have core antibodies quite early. And those core antibodies will persist for life, even if the person has cleared the virus and recovered. Obviously, vaccinated patients won't have core antibodies at all. So the tricky thing with core antibody is that it helps us determine whether this patient's response is due to vaccine or virus. What it doesn't tell us necessarily is when that virus was. So a core antibody level by itself just tells you that at some point this patient has seen the hepatitis B virus. Now, there is another way around that though. What we can do is use IgM to help make the difference. The IgM anti-HBc antibodies are highest in the first 6 months. So if somebody's actually got IgM present, this is likely to be an acute infection. If they don't, it's likely to be an old infection. So that can help determine if it's new or old, because the HBc antibodies by themselves won't let us know that difference in time frame. So now back on my virus picture, we've got the core antigen mentioned, and now I've got a little picture of core antibodies attached to that. Let's move on to talk about the viral envelope and the envelope antigens. So E is for envelope. So the HBeAg is the E envelope antigen. Now this is also inside the virus, but it's an indicator of active replication of the virus when there's high virus turnover early in infection, and in some people who have chronic active hepatitis, you see lots and lots of viral turnover, lots of cells being replicated and destroyed, lots of viruses, being replicated and destroyed. And because of that, you'll see lots of envelope antigen being spilled and being seen by the immune system. The presence of envelope antigen indicates high infectivity. Now, how you remember all of these one of the things I use, and it's probably a little bit of a stretch, but it works for me. If I need to post a letter to somebody, I'll put it in an envelope. If I want to post lots of letters to people, I need lots of envelopes. To me, and the way my logic works, if somebody's got high envelope antigen levels, they've got lots of envelopes to send lots of virus to people. They're infective. That's the way I remember it. I don't know if that's useful to you, but it works for me. Envelopes means sending out lots of infection. Now, what happens, just like with the others, is that antibodies will be formed to the E antigen, and as the E antibodies go up, the E antigen usually disappears over time. The E antibodies will get rid of the E antigen. And you'll see on this slide again my little green star, which is my little symbol for an E antigen, and there's an E antibody. Back on my big virus picture, I've now attached the little E antibody to the envelope antigen where it belongs. The final thing we need to mention is the viral DNA. So now that we understand what all the antigens and antibodies do, where does the actual DNA of the virus fit in? So the Hep B DNA is actually inside the virus, and we can actually detect that with PCR. So polymerase chain reaction is quite sensitive, and it allows you to detect any of the DNA that's in the blood as active viral particles are replicated or destroyed. Now you can do a qualitative test for a screen, which will give you a positive or negative result. Is there Hep B DNA in this person's blood? If it's positive, you can then do a quantitative result to find out exactly what the viral load is. This gives you a really good indication of somebody who has chronic hepatitis, of how infective they are and what the likelihood of ongoing damage to their liver is. So summarising what we've covered so far, the surface antigen is on the viral surface. High levels indicate acute or chronic infection, and it's also used to manufacture vaccine. When surface antibody is produced, it confers immunity, and it can confer immunity for life if the levels are high enough, and they reduce over time. Presence of surface antibody tells you this person is immune. It doesn't tell you whether it's vaccine or virus. Now the core antigen, as you remember, is a protein in the viral core, but not in the vaccine. We can't test for the core antigen, but we test its presence by testing for the core antibodies. So if someone has core antibodies, that means they've seen the virus, not just the vaccine. The core antibodies appear at the onset of symptoms and persist for life, and they indicate previous or ongoing infection. You can't actually tell whether the infection's new or old just from the presence of core antibody, but you can measure IgM to get a better idea if it's a new infection. The next antigen, remember, is the envelope antigen, and this indicates active viral replication and high virus turnover. You see it early in infection. You'll sometimes see it in chronic active hepatitis as well. It indicates high infectivity, lots of envelopes to send lots of virus out to lots of people. When envelope antibodies are formed, the antibodies go up and the antigen goes down, and that helps also to confer immunity. And then finally, remember that you can measure for the actual particles of Hep B DNA that are found in the bloodstream to get an idea of viral load. So with all of that pathophysiology now hopefully clear, let's have a look at some examples and see if they make sense. Let's look at this first patient. This first patient has HB surface antigen detected, HB surface antibody not detected, core antibody is detected, E antigen is detected, and E antibody is not detected. Now trying to rote learn that pattern, I don't know about you, but I would find that quite hard. So to me, I have a system of how to think about it. So the first thing I do is say surface antigens detected, which means this is probably something acute. Core antibody means that this is virus, not just vaccine. Okay, so the fact that we've got surface stuff happening and core means this is a whole virus. Now, there's no antibodies to the surface have been produced. So we've got surface antigen and no surface antibodies. So this person's not immune. The infection has not been cleared. The core antibody, as I said, makes it clear it's infection, not vaccine. The E antigen, remember the E antigen is for viral infectivity and replication, means the virus is actively being replicated. The E antibody means there's been no antibodies formed. So we've got lots of surface antigen with no surface antibody to make you immune, We've got core antibody to show us this is actually virus. We've got E antigen to show us that this is detected and that this is high viral replication and high infectivity, and we've got no E antibody. So what does all of that mean? This is most likely to be an acute Hep B infection, or it could be a chronic active Hep B infection, but with ongoing high-level replication. This person is likely to be quite infectious. There's a few other tests we can do to clarify whether this is acute Hep B or whether this is chronic active Hep B. Looking at that detected Hep C antibody, if you wanted to do a Hep C antibody IgM, that would tell you if this infection was less than 6 months old or not. And the other thing that you could do looking at this is also to look at a viral PCR to actually see what the viral load is, although it's likely to be quite high either way because this patient has either acute Hep B or chronic active Hep B with high viral turnover. Let's have a look at another one. This patient example number 2. Surface antigen is detected, surface antibody is not detected, Hep C antibody, sorry, not Hep C, Hep B C core antibody is detected, Hep B envelope antigen is not detected, and envelope antibody is detected. Again, that sounds quite confusing when you say it like that. Let's work through it. So they've got surface antigen detected and core antibody detected, so this is virus, not vaccine, okay? Because otherwise you wouldn't have core. Surface antibody is not detected, so while there's surface antigen, there's no immunity yet. Core antibody is detected, so we know it's virus. We have E antigen not detected, so it's not in a process of high viral replication. E antibody has been detected, so that's why there's no E antigen anymore. So still surface antigen without immunity, but no longer high viral replication. And definitely virus, not vaccine. So what does that mean? Well, if you've got surface antigen in your bloodstream, you don't have antibodies against it, but you're not necessarily active at the moment with viral replication, Hep B carrier. So they've got chronic hepatitis, but they're in a low replicative state because the EAG is negative. They don't have envelope antigen, so they're unlikely to have high cell turnover, but they also are not immune. They're in that limbo in the middle. Liver function tests and a Hep B PCR would be useful to actually work out what the viral load is for this person. Let's look at the third example. So surface antigen in this patient is not detected, but surface antibody is. So with that alone, we know this person, assuming the levels are high enough, this person's immune to Hep B. Now, if you're just looking at those first two columns, you can't tell whether they're immune from a immunisation, from a vaccination, or from an infection, because surface antibody could come from either. But the next column, the core antibody, tells us this is virus. Now, the E antigen is not detected, so they're not in high levels of replication and high viral turnover, and E antibodies have been formed, and that's why the E antigen has gone away. So, no current surface antigen, no current E antigen, E antibodies, core antibodies, and surface antibodies. So this is probably a resolved hepatitis B infection, and this patient should have immunity. If you don't have a clear history of hepatitis B infection and you want to know how old it is, then measuring the Hep B core antibody IgM would give you a better indication of how old the infection was. If there's IgM positive, it's less than 6 months old. But at the end of the day, we probably should get a quantitative measure of those surface antibodies to see how high they are. But if they're high enough, this patient's had hepatitis B, got better, and they're likely to be immune. Let's look at another one. Now this one's an interesting one. The patient has surface antigen positive and everything else is negative. Okay, so they're surface antigen positive but they've got no antibodies. They've got no core antibodies, so this isn't virus. They've got no E antigen, so there's no viral replication. They've got no E antibodies formed because there's no E antigen. So what's going on? This is a strange one. There's two possibilities here, really. Is that someone's taken this blood immediately after a patient's had a vaccine. So that surface antigen is actually synthetic. and is circulating because the patient's been given a vaccine and that body hasn't formed an immune response yet. So maybe they had their vaccine a week ago. Now that's pretty unusual. There's no reason you do that. But the other thing is this could be a false positive. This would be a very unusual situation to look at this, where you'd have antigen and nothing else. So I'd suggest if you ever saw one of these, we should be testing it again. And let's just do one last example. In this one I've been a bit tricky and I've actually given you some measurements. So for this patient, we've got surface antigen not detected, but surface antibody is detected. I'll come back to the measurements later. But surface antibody is detected, which means this person has immunity. Is it to vaccine or is it to virus? We don't know from those two columns. So let's look at core antibody. Core antibody is not detected, which means this is vaccine, not virus. There's no E antigen, there's no E antibody. So this is vaccine, not virus. And we've got a quantitative measure here of greater than 10 milli-international units per mil. So what does that mean? Of greater than 10 milli-international units per mil are adequate for someone who requires immunity. So this is particularly for people like healthcare professionals that are in high-risk professions, and is likely to confer lifelong immunity. For more details on the measurements and who needs to be tested, you need to check the Australian Immunisation Handbook. But I think it's interesting to know that you don't just get a yes or no reading. If you ask for it, you can get a quantitative reading. And this is how we measure if someone is immune. So no surface antigen but surface antibody, no core so it's not virus, no E so it's not active. This is vaccination response. Look, I hope that was helpful and shows you a way to work it out. One of the great things now is to actually try and find some results and work them through in your head. Go through systematically. Is there surface? Is there core? Is there E? Antigens, antibodies, and making it clear. There's an article that's published in Australian Family Physician in 2012 that I think is a really good one on hepatitis B serology. And this one's worth looking at, by Vanessa Tal and Benjamin Cowie. It explains it as well. It does have a table too, you know, they've all got tables, but it's a nice explanation in this one. If you're really into it, then this particular document on interpreting hepatitis B serology is quite complex. It's probably the reference guide. It's not as easy to read, but it's very thorough and very good. So over 20 minutes, a little bit longer than I'd hoped, but hopefully that's a helpful, useful tool for you. Go have a look at some results and see if you can figure it out for yourself. If you need any help for AMC exams, RACGP exams, or pesky interviews, come find us on imgsos.com.au or find us on Facebook. Thanks. Have a great day.